the fluid is centrifuged and a cell block is created, and the cytological examination can be carried by sphere microscopy, immunohistochemical analysis. There are certain ways where rapid cytologic techniques are also used, and otherwise the conventional cytological evaluation is by HND or Papanicolaou staining. However, they have lower sensitivity and poor negative predictive value. Other modes are like immunohistochemistry and usage of RT-PCR. So what is the relevance of cytological positivity? So there is two schools of thought where with a wide range of thought process. So Japanese gastric cancer treatment guidelines, they consider positive cytology even without signs of peritoneal carcinomatosis in laparoscopy as a distant metastatic disease. However, European Society of Medical Oncology is uncertain whether the patients can be treated with a curative intent or they should be considered as metastatic. Anyway, but the peritoneal cytology patients who undergo tumor resection without any treatment generally have higher increased risk of peritoneal recurrence and shortened overall survival. So with this thought process of whether to consider it as metastatic or any curative intention can be done in this kind of patients. So can these patients be subjected to neoadjuvant chemotherapy and followed by restaging and followed by definitive surgery? There is a 30 to 50% conversion to PC negative after neoadjuvant chemotherapy by FLOT regimens. May have these patients, this subset of patients may have better outcomes compared to obvious peritoneal carcinomatosis patients. So this is a paper published in 2010. Out of 48 patients restaged after chemotherapy, 46 patients converted to negative cytology, and they had significantly improved disease-specific survival compared with persistently positive cytology after neoadjuvant chemotherapy. This is another paper with similar results, where peritoneal cytology being positive followed by neoadjuvant chemotherapy resulted in better overall survival than the obvious peritoneal carcinomatosis group. So this here we can see this the orange line where post neoadjuvant chemotherapy there is a positive improvement with PC negative status, having good response when compared to the patients of obvious peritoneal carcinomatosis and positive cytology. So there is a debate because even in gastric cancer patients, with the limited disease, we go for HIPEC surgery. So in such kind of subset of patients, does HIPEC will be helpful in peritoneal cytology positive patients in addition to neoadjuvant chemotherapy? So no data is at present for this kind of picture. They are for future studies. Take home message: staging laparoscopy is indicated for potentially resectable gastric cancers. Peritoneal cytology has an additional 5 to 10% of yield. Early stage gastric cancers, the peritoneal cytology yield is very low. So PC positive patients, there is a debate between metastatic or still resectable with two schools of thoughts. However, peritoneal cytology positive patients have a prognostic value. HIPEC for peritoneal cytology positive patients are not yet fully established. They are for the future studies. Thank you.